Dr. Vikas CHADHA now. Dr. Vikas CHADHA is a consultant ophthalmic surgeon at the Tennant Institute of Ophthalmology, Glasgow, Scotland. Dr. CHADHA is the training program director for the West of Ophthalmology, Scotland Ophthalmology Training, which is the largest training program in Scotland. He is a past executive member of the British Oculoplasty Surgery Society. So a very warm welcome, and we look forward to hearing your talk on orbital radiotherapy.
Thank you. Thank you very much for that kind introduction. It's an honor to be invited to this grand congress in a city that I'll always call home. Today, my remit is to share my thoughts on orbital radiotherapy. Most people in this room will be very familiar with the utility of external beam radiotherapy for the orbit. While I'll briefly talk about the indications, my focus very much today is going to be on the challenges that we've faced in decision making as well as in terms of complications. And hopefully the collective experience of the panel will be able to give us some solutions. External beam radiotherapy for thyroid eye disease is fairly well established. Perhaps the debate essentially is what purpose you use it for. Does it improve ocular motility? Does it decrease clinical activity? Or does it actually prevent dysthyroid optic neuropathy? My feeling is that to some degree it's all three, and logically it will be most useful when used in the active phase. In general, the dose for thyroid eye disease tends to be between 20 and 25 gray, delivered in 10 fractions, although some centers have used some lower dosing regimes. It may be used with or without steroids or steroid-sparing agents. In our setup, we find that the maximum use of orbital radiotherapy for thyroid eye disease is in the patients where ocular motility restriction is the most prominent symptom. There should be no imminent threat of compressive optic neuropathy because we know that that orbital radiotherapy in thyroid eye disease will not act immediately. And these are the kind of patients who tend to give us the best response. One could, of course, argue, is that the steroids that we would often concurrently use, or is it just a natural regression of the disease? And that's open to debate. The use of radiotherapy in orbital lymphomas is perhaps undisputed. Primary orbital low-grade lymphomas seem to respond best, and we have the backup of our hemato-oncology colleagues for this. Our role here is perhaps just to give a pathological diagnosis in the form of an orbital biopsy and then hand over to hematology. The dose is very similar to thyroid eye disease, but many centers have tried ultra-low-dose radiotherapy using just 4 grays for orbital lymphomas. I'm not sure about centers in India, but in Glasgow, we certainly haven't been brave enough to go down this route. Whatever you use, these centers report more than 90% success in terms of local control of these lymphomas. This is a typical MALT lymphoma of the orbit, and you can see that in general, we get a really good clinical and radiological response with orbital radiotherapy. In the doses that we use orbital radiotherapy for thyroid eye disease and orbital lymphoma, it's generally very well tolerated. Dry eye seems to be the most common complaint. Radiation retinopathy is very rare, even though we would still have some caution in terms of using it in diabetic patients. Cataracts is, of course, the most significant complication, but in general dealt with very well. We looked at our cohort of patients who underwent radiotherapy and developed a cataract, and in general, the visual outcomes are no different to any other cataracts. Perhaps worth knowing that there is a higher rate of posterior capsular opacification in these patients and a higher rate of cystoid macular edema, but both of these don't seem to impinge on the final visual outcome of these patients. Now, the area of other orbital malignancies is perhaps where there is a bit more variation. You can use orbital radiotherapy as an adjunct for cure of many malignancies, or you could use it with palliative intent, perhaps both in malignant and in benign tumors. 2 examples of successes before we move on to the complications and the challenges. This is a lady with adenoid cystic carcinoma, unfortunately on the side of her only seeing eye. This was treated with radical radiotherapy, 65 grays, along with cisplatin, and she's had a really good response with no evidence of metastasis. Here's another patient where radiotherapy is used in the same dose, but with palliative intent. A gentleman with a basal cell carcinoma, really unfit for any major surgery, and with the use of radiotherapy for the purpose it's been used for, it's a reasonable result. But of course, it's not always smooth sailing. Let me use an index case to illustrate that. This is a gentleman with a ciliary body melanoma in 98, treated with resection and a ruthenium plaque. 17 years later, the patient developed an anterior recurrence of the melanoma, and knowing that often these are from the edge, we treated it with a second ruthenium plaque. Probably an incorrect decision, because soon after, the patient had a second recurrence and underwent enucleation. Extensive discussion about this patient at the MDT, and the eventual conclusion was not to give radiotherapy. Unfortunately, just a few years later, this became the first patient that we've seen to develop an orbital recurrence of a uveal melanoma. He underwent a lid-sparing exenteration, the margins were closed, and this time the MDT did recommend radiotherapy, and he had 65 grays. He was lost to follow-up for a little while, came back with an episode of herpes zoster ophthalmicus, and then developed a wound dehiscence. So when we reviewed the case, we had multiple questions to answer. Could we have given him radiotherapy after enucleation to prevent an orbital recurrence and the subsequent exenteration? The problem, of course, is there is no consensus. And if you talk to various peers, there are conflicting opinions. And then on the other hand, did we need to give him radiotherapy after the exenteration? Did we actually give him a survival advantage? And given the subsequent complication, was that really required? And once again, there is absolutely nothing in literature to give us a clear steer on what to do. So we looked at our enucleations for uveal melanoma in Scotland, and we looked at the patients who had extrascleral extension on pathology. This particular group, 7 out of these 32 patients had external beam radiotherapy. And looking at these 7 patients, unfortunately, 2 of them developed severe socket contractures. So that's a 29% complication risk, quite high. At the same time as we published our results, Moorfields also published their results, and both of our studies concluded the same. There was no difference in all-cause mortality between those receiving external beam radiotherapy in these particular situations versus those who were observed. And what we both found was a high risk of socket contracture. Let's go back to our patient. Post-exenteration EBRT, resulting in a wound dehiscence. We then had 2 more cases: an adenoid cystic carcinoma, lid-sparing exenteration, radiotherapy, and then a wound dehiscence. This was a patient with a squamous cell carcinoma who underwent an exenteration, reconstruction using flaps, and then 6 months after radiotherapy, another wound dehiscence. So if you look at these 3 patients, there's really very little common amongst them. Perhaps one thing, or maybe 2. The first and foremost is the whopping dose of radiotherapy. 65 grays in all of these patients, clearly considered necessary as an adjunct to surgery for curing these malignant conditions. And the second common thing, I suppose, is the bruised ego of the surgeon. Unfortunately, one of them was me. So, in summary, radiotherapy is no doubt a friend. Proven benefit in thyroid eye disease and orbital lymphomas, and a very useful adjunct in many other malignancies. However, in specific situations of uveal melanoma with extrascleral extension, patients going under enucleation, there's really no evidence that adjuvant radiotherapy helps. We still offer it. We offer it to the patients who have extrascleral extension more than 5 millimeters, but really very little evidence to back that up, apart from a full multidisciplinary team discussion in order to give that recommendation. In terms of an orbital surgeon, we've got to watch out. Radiotherapy post-enucleation has a high risk of socket contracture, and post-exenteration has a very high rate of wound dehiscence. We now routinely started using a temporalis flap under the skin in order to obliterate the cavity completely if we are anticipating that these patients will undergo radiotherapy. Thank you very much for your attention.
Well, wonderful talk, Dr. Vikas, and vast experience, I must say, about EBRT. So, thanks a lot.